Hello, everybody. Allow me to introduce myself. My name is Thomas Aurelius Dharma from Trisakti, and today I will be presenting about my research on bone regeneration comparison between non-autograft and autograft bone graft. So first of all, introduction. So tooth loss will cause lack of stimulus for bone formation, which will cause alveolar bone loss. And there are two types of alveolar bone loss, which is vertical bone loss and also horizontal bone loss. And this will cause a problem for dental implants, which they require adequate bone thickness. The ideal residual bone for dental implants is 3 millimeters more than the diameter of the implant. Now, this could be fixed with bone graft. So bone graft is a procedure that replaces missing bone with a bone substitute. And this bone substitute or bone graft will support the bone regeneration of the bone. And there are four types of bone grafts. There is autograft, which are grafts that is taken from the patient's own tissue, and then there's allograft, which are grafts taken from the same species or from other human. There is xenograft, which are grafts taken from a different species, and there is alloplast, which are grafts that are synthetic. So the non-autograft group are allograft, xenograft, and alloplast. So autograft is the golden standard of bone grafts. So the advantages are autografts are osteogenic, osteoinductive, and osteoconductive, which is ideal for bone formation. But autograft is associated with lots of disadvantages, which are the need for two surgeries and the donor site morbidity. There will be more risk for surgical infection and chronic pain post-surgery, and also limited yield of the graft. So this begs the question, does the result of the treatment with autograft justify the risk, or can we use non-autografts and get the same result? So using non-autograft bone grafts can avoid the risks and disadvantages that comes with autograft bone graft. So this review describes the bone regeneration of non-autograft bone grafts compared with autograft for dental implant placements. So for the method is scoping review, and the research period is from September to December of 2021, and the population and research sample. So the aspect being studied is the radiographic description of bone regeneration of non-autograft compared with autografts that is found on the literature. And the review method is PCC concept, or the population concept and context. And this is the Prisma flow diagram that is going to be that is used. And these are the keywords used for the Boolean search. So this is the results after using the keywords in the Boolean search. So the database we use is PubMed and Wiley. So after we use the Boolean search, we had 9 studies that is going to be included in the scoping review. And so the articles that are found and used, there are 9 articles, which compares autograft with allograft, which are 3 articles, and then 3 articles that compares xenograft with autograft, and 3 articles that compares with autograft with alloplast. And this is the main result. So in the 7 articles they found no significant difference found on any of the measurements, while in 2 articles there are significant difference found on one of the measurements. And so the measurement that are used in the studies are vertical dimensional changes, which is found in 5 articles. There is also horizontal dimensional changes, which is measured in 2 articles. Bone remodeling, which is measured in 3 articles. Radiographical area changes in 1 article, and forearm changes in 1 article. So this is the data extraction table. So this is the discussion. First of all, autograft with allograft. So in of the 3 studies, 2 studies found no significant difference, while 1 studies found 1 significant difference. So the first article is from Kloss et al. They found no significant difference between FDBA allograft with mandible autograft on block grafting procedures. And then for the criteria measurement of remodeling, 3 of the articles they evaluate the remodeling, so they found no significant difference in 2 articles, but in 1 articles they found that corticocancellous allograft showed a significant difference when compared to autograft. So the corticocancellous autograft showed more radiographical area than autograft, but with the biggest resorption rate. So the author concludes that the ratio of cortical and cancellous bone is more substantial than the source of the bone itself. So the conclusion for autograft and allograft comparison is that allograft shows similar results and changes compared with autograft. And also the architecture or the ratio of the cortical and the cancellous bone, it significantly affects the graft incorporation and also remodeling. And then autograft compared with xenograft. So in the 3 studies, 2 studies found no significant difference, while 1 study found 1 significant difference. So in the first article by Bordon et al. In sinus lifts, they measured the distance of the apex of the dental implant to the sinus floor. So in the first year, they found significant difference, which xenograft yielded more distance. So they performed better than autograft. But on the second year, the difference diminished, so they found no significant difference on the second year, which the author concludes that xenograft undergoes a slower rate of resorption than autograft. And this is the second article for autograft and xenograft, which is also on the sinus lift procedures. So they measured the reduction of bone height 5 years after dental implant placement, and this is the pie chart. Found no significant difference in this article. And then for the third article for autograft and xenograft comparison, in Beans, SP et al., in block grafting procedures, they measured marginal hard tissue height, buccal hard tissue height, and also buccal hard tissue thickness, which they found no significant difference on all 3 measurements. So the conclusions for autograft versus xenograft is that xenograft undergoes a slower resorption rate than autograft and has similar properties with autograft and can be used for excellent long-term results. And then for autograft and alloplast comparisons, on all 3 studies, they found no significant difference. So on the first article from Kim YK et al., in sinus lift procedures, they used 30% beta TCP and 70% hydroxyapatite versus tooth autograft. So they found no significant difference on vertical dimensional changes. And on the second article from Zichterfeld et al. On sinus lift procedures as well, they use 100% beta TCP versus chin autograft, and they found no significant difference on vertical dimensional changes after 5 years. So beta TCP is an alloplast that has a rapid rate of resorption, which is not ideal for long-term results, but the similar results to autograft, the author mentioned that there's a probability that there were parts of the bone graft that were not fully resorbed. Hence why the alloplast has similar results to autograft in this case. And then for the last article from Dr. A.M. and et al. In the sandwich osteotomy procedure, they use hydroxyapatite versus intraoral autograft, and they found no significant difference in vertical bone changes after 1 year. So in the 3 articles, they compared alloplast and autograft in the vertical bone changes and showed that alloplast yields a similar vertical dimensional changes compared with autograft. So there are limitations of the study. So the limitations are, first of all, the limited time on the study and the probability that the keywords used for the Boolean search in the database does not include all the article that matches with the inclusion criteria of the scoping review. And also in each of the study, they have different and variations of measurement parameter on each study, so it becomes difficult to compare each study. And we also excluded histomorphometric measurements. So for the conclusion of this research is that autograft and non-autograft for dental placement tends to have similar dimensional changes on vertical, horizontal, and remodeling that does not differ significantly on radiographic evaluation. And that's all for my presentation. Thank you for listening, and I'm happy to take questions.